I know that you've kind of been dealing with this meningioma for a little over a year, right? So you had the surgery back a year ago in June.
Yes.
But it was before that you had some symptoms, and it was a few months of some changes before we picked up on this.
Yes.
We found out that clinically it looks like you likely harbor a mutation called NF that we think is why you have these meningiomas, but also the other tumors in the brain, which it does put you at some predilection to forming tumors, so that more meningiomas can happen in your lifetime, both with and without treatment. And so we have to be cognizant of that, but also follow you and make certain that we help you as you get older to kind of do a couple of things. We want to maximize your quality of life. We want you to live well with your disease, but we also understand that we have to try to do our best to control these areas because they can take away function or potentially be deadly depending on how big they get over your lifetime. So a lot of people that have this disorder can still do well into their 30s, 40s, 50s and live a normal life. But a lot of, unfortunately, these tumors, depending on where they grow, you might manifest new problems like you're seeing now with the change in the orientation of the eye, or loss of vision or changes in function because of the tumors. So we'll do our best to work with the surgeons to try to manage all of these tumors that you are going to be dealing with for your lifetime. Does that make sense? Typically, for someone who in your situation, we try our best to not radiate unless there's significant problems that require our help. And so oftentimes when we see these types of tumors, so the tumors that we're talking about are the one that we're most concerned about, which is the one that's near your left eye. But you also have the ones that are sort of in your hearing apparatus. Those and the other areas will likely just watch to see how they change over the next few years or decades, and really only manage them symptomatically. So typically areas that grow or areas that are starting to cause trouble or symptoms, we try to consider surgical options first. Over the years, we may develop new systemic therapy options. So there are clinical trials happening in adults, but also some pediatric communities around the world where we're trying to use different drugs, drug therapy. One that's been used in NF patients is called Avastin. So sometimes we'll do that for people if these hearing tumors ever grow. But there's different drug therapies that are considered more experimental that we could think about one day. But the areas we think are most useful for treatment to help control tumor are surgery, so a local treatment, or radiation, another local treatment.
Okay.
The reason why we do surgery so often is because it spares the additional risk that radiation can give. Okay. Because the surgeries have their own set of disadvantages of needing anesthesia, the local injury to areas that you're going after, so hurting a nerve or hurting local areas or causing ischemia or damage with surgery can happen. Okay. And so those are some of the disadvantages of doing surgery, but the advantages are it spares normal areas outside of where the tumor is from additional injury, like what radiation can potentially do. Because radiation needs to pass into the tumor, there are some areas of the normal body, like brain, craniofacial, bones, structures like the eye, lacrimal gland, which produces tears, will all have some radiation to them and can manifest as an injury because of our radiation treatment. Okay. There's also radiation that can sometimes go to other normal parts of the brain or structures that could 10, 20, or 30 years from now cause some damage or another tumor. The risk of another tumor is what we commonly worry about when someone has NF, so the neurofibromatosis type syndrome, because we think that there's an election to forming tumors. So by giving some of this ionizing radiation, we worry that they will be causing a tumor. The challenge is that although that is a risk, I think that it is far outweighed by controlling a tumor like his that's causing so much morbidity already. Causing sort of the proptosis can lead to a lot of pain, dysfunction of that area. So our hope is that the radiation's impact on controlling the tumor will far outweigh the potential and low risk of a secondary tumor. Does that make sense? Okay. And then that conversation also comes into play when we think about the two different ways we can treat with radiation. One is called photon-based. It's like light in the room. flipping a light switch on. Light with photons passes in and out of the body. So we will focus the radiation over the tumor, but there will be low dose, very low dose, to other parts of the head and brain. And so that low dose for most people, especially at like much older adults that get radiation, has very little long-term manifestation. The younger you are, or if you have a genetic predisposition, that's where we worry about potential secondary tumors because of that very low dose, kind of getting put into other areas, potentially leading to something many decades later. And so that is slightly different when you use proton therapy, because proton therapy only enters. It doesn't exit like a light particle would.
Okay.
And so what that does is the low doses to say over here or down here would be none. And so that would lower the risk of secondary tumors, but there still is a risk, and this is kind of where the nuance comes, there's still a risk of tumor formation in the region that we treat. Does that make sense? So high to intermediate dose with proton therapy can still cause secondary tumors, and that risk is inherent to just giving the radiation. Does that make sense? Mm-hmm. So the main risk differential is in the low doses that are different with photon therapy. Does that make sense?
Yes.
So we're thinking about dropping a risk that we think is one in a few hundred over the next 30 years to probably maybe 50% of that. But again, we're dealing with small numbers already. So it's like saying, we'll just choose a number. If we're saying 5% risk in 30 years, it may be 2% for protons. So although that's a large drop, it's a low risk with both. Does that make sense?
Yeah.
And there are some differences with photon therapy that I think are also important. We can do a nicer job of keeping a very conformal radiation treatment, making certain that we can bend to this kind of the tumor's not a perfect circle. We can much easier control where the dose is being bent with the photon treatment. We also have to worry sometimes with what's called uncertainty. This tumor has a lot of air, fat, and sort of soft tissue and bone around it. That can have implications on where this proton goes and how far it goes. It's called what's called uncertainty. And so when we deal with this uncertainty with protons, it can sometimes go a little further than we thought or not as far as we thought. So we build in some extra high dose radiation around the tumor, which is a little bit disadvantageous in this situation because tumor's already touching the eye. The tumor's very nearby the nerve of the vision of that left eye. And tumor's already in the lacrimal gland of the left eye. Does that make sense?
Yeah.
And so the main disadvantage to the proton therapy is I worry a little bit that we could inadvertently overdose or hurt some of the optic structures because we're on top of them already. Does that make sense? If we had more space away from them and we could more easily control the radiation dose in that area, I think proton therapy is a no-brainer. I think that the other disadvantage of proton therapy, and this is true anywhere in the world, but also in the US, is that there's very few proton centers available to most people in the world. And so photon therapy is most often used in these situations, both on trials that we've done in the past, but also around the world. The two proton centers in Ohio are in Cincinnati and Case Western and Cleveland, and you'd have to relocate for about 6 weeks to do the treatment. And so that's not always feasible for people because it kind of uproots someone out of their lifestyle and can be somewhat difficult financially to relocate a family to a new place if work and other things won't be adjusted for. And so I think those are the types of things we'd have to worry about because I don't know necessarily that protons is definitely better here. Like if I knew, like say we were treating the entire brain and spine, if we were treating a much bigger area and we knew the toxicity would be much, much less, we knew that the outcome would be much, much better, then I think we would definitely say, that type of lifestyle change and the toxicity financially and emotionally to the family and to you would be worth it. But I think in this situation, because I think they're both very similar, there's likely some equipoise between the two. I don't know necessarily that I would say you have to do proton therapy here. Does that make sense? You definitely could. I think there's some benefits to it, also some downsides or disadvantages to it. That's also true with the photon therapy. We'll be much more conformal with the photon therapy, but disadvantages putting more low dose throughout the brain. Does that make sense?
Yeah.
And so, what are your thoughts on relocating or doing proton therapy if you've heard of it before? And would that be something